Good morning, everyone. Let us start. In 1847, Robert Liston performed first amputation in 15 seconds, but he injured his one junior also. And after that operation, the patient died, the junior died, and a person who was standby who also died. So that was the first literature evidence where there was 300% mortality. But why sepsis is so important to us? We these days boast as our perioperative physicians, and we come across and give anesthesia to many people. And sepsis is such a vague aspect, and that's why I chose today's topic to share with you whatever I little learned over the period of 10 years. But we must understand that a sepsis is a systemic manifestation of body's response. It's the body's response to infection and trauma. It's a peculiar version of the stress response, and it affects virtually every system of our body. Severe sepsis accounts to almost 1 to 2% of hospitalizations and 25% of our ICU admissions. So if you are going to get any patient from ICU, the bell must ring in your mind. It's a second leading cause of the death in non-coronary ICU, and mortality is as high as 30 to 50%. And as an anesthetist, we have very unique skills in resuscitation, monitoring, titration, giving anesthesia, and taking care of such patients. So let us move on. Whenever we say sepsis, we always cater to such calls, isn't it? Our surgical colleagues are more interested in removal of the source or damage control, the source control. So there is a drainage of abscesses, debridements, device removal, in prosthetic valves or definitive measures like infective peritonitis for any septic patient. And we do get any such call. From their side, they will always say, oh, it's just a 10-15 minutes debridement. But is it so? Why I'm saying that in Bible, Jesus said there is no marriage in heaven. This confirms that this marriage concept comes from hell. And taking care of such patient of a sepsis is as good as hell. Why I will come to that. And it's right. So right from 2001, various societies have tried to define various pathological entities like bacteremia, septicemia, SIRS, sepsis, severe sepsis. So severe sepsis was denoted as when there is organ dysfunction, hypotension, hypoperfusion. There was an entity called septic shock, then sepsis-induced hypotension. And there was a lot of ambiguity. It's like this. But after a few years, the diagnostic criteria for sepsis were laid down, which are very important to us as an anesthetist. So first were the general parameters and symptoms, where there is a fever, hypothermia, tachycardia, tachypnea, altered mental state. Then came the blood markers, where there is a WBC count more than 12,000, or C-reactive protein, or plasma for calcitonin, and so on and so forth. Along with, there were the hemodynamic changes. So the hemodynamic parameters were set in. The organ dysfunction was very much evident in the form of hypoxia, oliguria, creatinine clearance increase, coagulopathy, absent bowel sounds, and hyperbilirubinemia. And most important, the tissue hypoperfusion, where the lactates were high, decreased capillary fill there, and mottling was seen. These are very, very important to us as an anesthetist. And we must understand that the sepsis is very heterogeneous. There are a lot of genetic factors, the comorbidities, depends on source of infection, immunological status, the shock, the hypotension, and the organ dysfunction. And on a time axis can go as fast as in 1 to 2 hours, or sometimes 1 day to 2 days. Right? So whenever we say sepsis, it goes without saying that sepsis is equivalent or synonymous with infection, but that is not so. There are so many other non-infective causes of sepsis, and we cater to such patients and we give anesthesia, like severe trauma patients, when there is a hemorrhage, patients as common as myocardial infarcts, pulmonary embolism, diabetic ketoacidosis, pancreas, burns, anaphylaxis, so on and so forth. So whenever you are catering to these patients, at the back of your mind, you must understand that the sepsis is the pathology. Then we must understand, as I told you, that sepsis is a continuous process. So there is an infection or trauma, then there is a SIRS, then sepsis, severe sepsis, and septic shock. But what is important to us as an anesthetist, and I explain. Out of that, the sepsis and sepsis with persistent hypotension are the two major subsets which we should cater. When there is a sepsis, usually it is life-threatening organ dysfunction has already set in, suspected or documented infection is there, and acute increase of a SOFA score more than 2. Here the sepsis mortality is more than 10%. So every 1 in 10 patients what you are catering may succumb. As against when there is a sepsis with persistent hypotension, that is when you require the vasopressors to maintain the BP above 65, and when the serum lactates are high, the hospital mortality is almost 4 times. That is 40%. How do we score these patients? And when the patients are in ICU, we have the SOFA scores, and so many parameters are taken into consideration, like respiration, coagulation, liver enzymes, cardiovascular status, central venous system, and renal parameters. But that is when the patient is in ICU. As an anesthetist, when we attend a patient for an emergency surgery, Is there any other way? So here comes the other way, which is called as a quick SOFA score. The patients here, when we cater, they are ill looking. You can say there is something wrong with this patient. They are drowsy, irritable. Sometimes they may complain of fever, feverishness. They say, I'm not well. There may be some vomiting, diarrhea. Whenever such ill-looking patient you are having look at it preoperatively, think that sepsis may be the real cause. Here comes that quick SOFA score. So if you don't have the biomedical test at your hand, this is very simple score where the Glasgow Coma scale is taken into consideration when it is less than 13, that is altered mental state status, fast respiratory rate more than 22, and a systolic blood pressure less than. If two or more criteria are present, then it suggests that greater risk for the outcome and he may be a sepsis candidate. So, is this quick SOFA sensitive? The evidence is quite strong that the quick SOFA as compared to the SIRS news or the news as a single screening tool for the sepsis can be helpful. So, how do we manage such patients? If we boast ourselves as in perioperative physicians, this is what is our one bund. First, we measure the baseline lactate levels, we obtain the blood cultures, administer broad spectrum antibiotics, begin rapid crystalloid infusions to do the volume resuscitation, and apply vasopressors of hypotension. These bundles are designed worldwide, so the outcome can be measured or can be compared. So for lactate, I will talk to it much later in depth. But these days, there was a lot of importance given to the baseline lactates. But now the evidence is weak and the quality of evidence is low. You see the recent literature. So this was designed across the world because how to compare the mortality, morbidity. So as I explained to you in first hour bundle, if you take care of these maneuvers or these steps, then we can compare how the patients behave in the next few days or the hours. Antibiotic therapy guidelines. Antibiotic therapy is the mainstay. We must understand that we have to begin the intravenous antibiotics as early as possible when you are suspecting a severe sepsis or a septic shock. Don't wait for the microbial culture 24 hours, 48 hours growth. That can be again retailored depending upon the drug sensitivity later. Why I'm saying that is very important. Here is a paper which shows that if you administer the antibiotic in first hour, the survival rate is as high as 80%. After 6 hours, it comes down to half, that's around 42%. And by 9 to 12 hours, if you wait for the cultures to come, it is almost one fourth. So the mortality rate or the rather survival rate reduces at the rate of 8% per hour. So whether shock is present or absent, or whether the definite or probable, all these quadrants, the antibiotic therapy has to start in first within an hour, which is in our hands if you are acting as a perioperative physician. How to do the fluid? The fluid resuscitation, it's very clear whether the crystalloids or colloid. There is no big role of colloids as such. The plain crystalloids also do wonders. You target the CVP at around 8 to 12. Give fluid challenge in the form of 1 liter or a half liter over 30 minutes. More rapid and larger volumes may be required when there is a tissue of sepsis-induced hypotension. And the rate of fluid administration should be reduced. The cardiac filling pressures increase without concurrent hemodynamic improvements, especially in the cardiac compromised patients. So for patients with sepsis-induced hypotension shock, we suggest that at least 30 ml per kg body weight of crystalloid should go in first 3 hours. The evidence of or quality of evidence is low, but yes, it does help. Lactate. What crystalloids to give? Normal saline or ringer lactate? Because when you infuse more than say 2 liters or 3 liters of normal saline, you are worried about the hypochloremic acidosis. But is the ringer lactate safe? Because we are going to measure the lactates very serially. Here is the answer. One ringer lactate contains around 28 milliequivalents of lactate. Is it isotonic? But sterile water is acidic. So when you add lactate, the pH shifts to 6.6 and it acts as a buffer. So it per se never causes lactic acidosis when the liver is functioning well. So don't worry, use the Harpon solution. And let us talk about the lactate. We understand that this is a product of anaerobic glycolysis. It is a marker of global tissue hypoxia and it has a prognostic value, especially the ascending or the descending levels. Whenever the level is more than 4 millimoles, even in microcirculatory normal markers, the cryptic shock is always there. So what we calculate is a lactate clearance, which is more important. And if it is more than 10%, it signifies a better survival. And we must understand that it is the strongest independent predictor of in-hospital mortality. So For adults with sepsis or septic shock, we suggest the guiding resuscitation to decrease serum lactate in patients with elevated lactate levels over not using the serum lactate at all. So there is a marginal evidence that we should. When we talk about goal-directed therapy, we all know that these are the static parameters like CVP of 8 to 12, the mean arterial pressure in between 65 to 90, the central venous oxygen saturation more than 70%, and the urine output at least half a ml per kg per hour, and we must maintain 30%. But what is more important than goal-directed therapy is, the fluid resuscitation has to be the physical examination and should not be based on the static parameters alone. So dynamic parameters are more important, and the fluid responsiveness can always be monitored and titrated depending upon what is your pulse pressure variation. If you have the even pulse oximetry or if an arterial line, we can always have the recently all the HP and other monitors give you pulse pressure variation or the stroke volume variation, and looking at that you can guide the fluid therapy. There are various other techniques to measure the cardiac output also in sepsis, like thermodilution, esophageal Doppler, TE, pulse pressure methods. Whatever you have in your center, as simple as just a pulse oximetry or even an intra-arterial line does wonders, because the esophageal Dopplers and everything were used in past, nowadays not used. And you may not have the very sophisticated things like little pico. This is very important for us as an anesthetist. Whenever there is a hypotension or a hypoperfusion with the MAP of less than 65, either there are two groups of patients. One group less hyperdynamic, where the cardiac index is low and the venous saturation is less than 30%. Or there is another group where they are hyperdynamic with a more cardiac index of 4.5. But in both the groups, whenever the preload is low, volume is the answer. And if the preload is high, the people or the patients with the less cardiac index, you need to add in inotrope. And in an hyperdynamic circulation, when the preload is even more, you require inotrope. But the first line of therapy is the vasopressors. So for adults with septic shock on vasopressors, we recommend the initial target mean arterial pressure of 65. It is proven beyond doubt, and it has a very strong evidence has been established that your MEP has to be more than 65. Then takes care of the end organ perfusion. I'm not going to go into the much of these details. This is basic physiology of flow volume curve, where the red line shows the contractility and the EAE green line as afterload. What happens in the sepsis is the shift to the left. Contractility is also hampered as well as the elastance. So when you try to correct it with a vasopressors, again we shift the EAE line again to the right, and the cardiac contractility, which is slightly decreased with the in the form of slope, gets corrected to the baseline. That's how we maintain the MAP and the cardiac output. Here are the drugs. I'm not going to go into details in this, basically for the students, range from phenylepinephrine to isoproterenol with their alpha and the beta activities. And this slide suggests most of the drugs what when we use, like epinephrine, non-epinephrine, phenylepinephrine, and vasopressin, and what are their recommended dosages, and what should be used and how it should be used. We understand that these all agents have dual activity. They act as an inotrope also, or sometimes vasodilator or vasoconstrictor like dobutamine and dopamine, but they act through various different pathways. So one group is through adenyl cyclase, another is through phosphodiesterase, another is with sodium potassium ATPase. So if you have to have the judicious mix of all, if one group is not functioning well. So when you use vasopressors, you have to maintain the MAP of 60. Non-epinephrine centrally administered is the initial vasopressor of choice. So the first drug of vasopressor of choice is norepinephrine. Use epinephrine as the first alternative agent in septic shock when blood pressure is poorly responsive to norepinephrine. Do not use low-dose dopamine for renal protection. That is old concept. In patients requiring vasopressors, insert an arterial line as soon as possible and practical. We can do the serial blood gases and lactate. This is another table showing how the norepinephrine should be used, their advantages and disadvantages, and epinephrine. Next slide we'll discuss at length later. And vasopressin. The vasopressin should be actually introduced early after norepinephrine if it is not fluid responsive. So for adult septic shock, we recommend using norepinephrine as the first line of agent as a vasopressors, and it has a very strong evidence. So it's the agent of choice. Use of dobutamine in patients is restricted to the patients who have a limited myocardial reserve because it is an ionodilator. It takes care of the SVR, though it's a hemodynamically hyperdynamic circulation and patients are vasodilated. In a poor LV patients, the dobutamine works sometimes better. And the supranormal values of predetermined levels of cardiac index are never to be achieved these days. That era has gone. So in adult patients with septic shock or inadequate mean arterial pressure, despite norepinephrine and vasopressin, then we suggest these days to start the epinephrine and not early. So here's the algorithm. When you are catering such patient, when there is a suspected infection, we look at the MAP. If it is less than 65 and if the lactates are more than 4, sepsis is established. But if the MAP is less and the quantitative resuscitation candidate, if the CVP you have to maintain at 8, you add on crystalloids, do fluid resuscitation, but still MAP remains 65, add a vasopressor, and then again do a serial lactate clearance. And if the lactate clearance is more than 10%, it's a good news. Your goal is achieved. But lactate clearance is less than 10%, look at the hematocrit. And if hematocrit is less than 30%, we transfuse blood. Or if the hematocrit is less than 30%, revisit with the inotropic agent. And we need to consider the mechanical ventilation because your peripheral perfusion is really hampered. This is in nutshell management of such patients. So in ICU, the patients and your surgical colleagues are more into control of the infections, and you get a call for this, like for UTI patients, the disease stentings, peritonitis for respiratory infections, pancreatic debridements, and these are very ill-looking patients. And I'll come to the anesthetic management soon. What is important in it? So this is not something uncommon when we get an emergency call for the severe emergency laparatomies. And these are the various conditions what your surgical colleague is more interested to handle. But how we should approach this patient? We must understand that these cohort of patients are very unstable cardiovascular system. Sometimes they can be with full stomach, so there is a risk of aspiration. There's an increased sensitivity for the sedation, and with minute doses of midazolam and fentanyl, they may just sleep and they will crash. There's an increased volume of distribution and impaired vasoregulation. And many times there is an underlying adrenaline insufficiency. So before induction, you must understand that you have to have adequate help in your hand. You should have rapid infusers, fluid warmers, the H2 blockers to take care of acid aspiration. Whenever possible, arterial cannulation, CVP line, and we must do an ABG on room air because we know what the baseline is. It goes without saying. The basic monitoring like ECG, pulse oximetry goes a long way. We need to pre-oxygenate these patients for 3 minutes. We have to think of RSI. Titrated dose of induction agents is the key. Even the smallest dose of 0.5 to 1 milligram of propofol can have a negative inotropy and there will be a decreased SVR and patient may have a refractory hypotension. Ketamine plus midazolam can be a preferred choice and inhalation induction is always delayed if there is already an ARDS or ALI. The central line is preferred for IV induction. Many times we do, there is a line peripheral 22 gauge or 20 gauge. We say, let us come, let us induce first and then take a central line. No, please, in such patients, do take central line under local anesthesia and start. We have to stabilize these patients first. Do not, in a hurry, start this case. That is the take-home message. Because your surgeon is in a big hurry. He said it's a 15 minutes, half an hour job, and do not compromise with the standard. And muscle relaxant of choice these days can be rocuronium, which can be reversed with sugammadex. So we understand that the MAC is decreased in severe sepsis, and given a choice, desflurane will be preferred over sevoflurane than isoflurane. And ventilation strategies is more important in very moribund patients, where we target the tidal volume of 6 ml per kg body weight, keep plateau pressures below 30, set PEEP to avoid lung collapse, maintain saturation of 95, and sometimes permissive hypercapnia may be beneficial. So these are the take-home messages from the recent guidelines as far as the ventilation is concerned. That high flow nasal oxygen over the non-invasive ventilation, there is no role, and it has a very low evidence. Prevent without any doubt are the strong evidence in the form of limiting low tidal volume ventilation strategy of 6 ml per kg body weight and plateau pressures of less than 30. Whenever possible, even in when there is a sepsis and ventilation is required, the prone position is proven beneficial. And if in a severe ARDS, is there any role of ECMO? It has a very limited role, but sometimes it can be helpful. Kidney failure as the any organ damage. In next 3 to 5 minutes, I'm going to come to an end. Then we can discuss. I suppose I'm not overshooting, but I'll take 3 minutes. The renal failure and the kidney is the main target, and the AKI leads to the metabolic acidosis. And compensation is by hyperventilation and is by increasing minute ventilation. So hyperventilation leads to worsening of acidosis and causes cardiovascular compromise. So leaving acidotic patient in with ARF on ventilator is a safer option than to claim boast yourself as a hero and say, "Oh, I extubated the patient on table." No, you are not doing good to such patient. Sometimes the intermittent hemodialysis with CVVH is considered equivalent, and CVVH offers easier management in hemodynamically vulnerable patients. When to use bicarbonates? Our surgical intensivists or the ICU colleagues are very, very reluctant to treat the acidosis unless the pH goes less than 7.15 and there is a significant bicarbonate deficit. But yes, there was a dictum which was told by us, our surgeons, that our teachers, that our vasopressors don't act if there is a acidosis, and we used to give empirical bicarbonate therapy. But yes, if it touches 7.15, please do at least a half correction. That may be helpful. Another debate in the sepsis is whether to use steroids or no. And here was the first study of ANA in 2002, which was an initial low-dose study, which proved beneficial. And then came the Cortica study, which was a very firm, a very good evidence, which showed that the reversal of shock happened in 3.3 days versus 5.8 days. But superinfection or the new sepsis was a problem. So what do we say these days? Whenever you want to use steroids, consider hydrocortisone over dexamethasone. Steroid therapy may be weaned once vasopressors are no longer required. And hydrocortisone dose should be 300 milligram per day. That is the maximum permissible limit with evidence 1A. And do not use corticosteroids to treat sepsis in the absence of shock unless the patient's endocrine or the corticosteroid is equivalent. So for adults with septic shock or ongoing requirements of vasopressor therapy, we suggest using corticosteroids. But the evidence is weak. You may try, you may succeed, but it's not a conclusive evidence. How about the regional anesthesia? Let us not touch the GA at all because it's problematic. Here is a paper which was published in 2018 where there are the 5 classic references where they said in thoracic epidural was very much helpful. Studies also demonstrated increased blood flow, the sepsis models, and the sympathetic blockade, and studies showing immunology and anti-inflammatory and antimalarial role of local anesthetic was postulated in 12, but I think more evidence is required. Yes, a regional anesthesia in hand with sedation or the general anesthesia may be a way forward. So, what are our take-home messages? The strong recommendations from 2021 guidelines. Initial fluid resuscitation has to be done. Crystalloid as a fluid of choice. Do not use hydroxyethyl starches. Initial target MAP of 65. Norepinephrine as the first line of vasopressor. Administer antibiotics within first 1 hour of recognition, and then go for empiric broad spectrum antibiotic later. Red blood transfusion only when the hemoglobin is less than 7, not otherwise. And volume strategies, the tidal volume less than 6 ml, the conservative fluid therapy in ARDS in patients without hypotension. Do not use PA catheter, it's obsolete now. Prone position, yes, for sepsis-induced ARDS. Do not use beta-2 agonist for the bronchospasm. And high flow nasal oxygen is of not that great help when it comes to a severely sepsis-induced ARDS. But prone position and elevated breath. Maintain sugar less than 180. Pharmacological VT prophylaxis and unfractionated low molecular reticulins. Stress prophylaxis, nutrition, and there is no big role in omega-3 fatty acids as an implement. So, dear friends, the rapid clinical assessment and initial fluid resuscitation, timely administration of antibiotics is the key in managing such patients. Careful induction and maintenance of anesthesia goes a long way, and we have to design a good post-op care So you have to take care of such patients, look not that sick, but can turn into very sick patients post-operatively in a good center where you would have ICU backup. So here is the reference worth reading: Surviving Sepsis Campaign Guidelines 2021. When you visit, it's an online special article, freely available, worth reading, and you'll get most of it what I have discussed just now. And when you go to up to date, even there is one very good article. So conclude, dear friends, we say there is a quote: by all means marry. If you get one good wife or husband, you will be happy. If you get bad one, you'll become a philosopher. It is by Socrates. And this holds true for even the sepsis patient. If you get a good patient, you'll be happy. But if you get a bad one, I'm sure you'll become a philosopher. Thank you.